Hello, hello. Mic check. Hello everyone. Hello students. Today's topic of discussion is INICET exam. All of you, all the best, all the very best for INICET exam which is scheduled on Sunday. Okay, on 5th November. So in this session is completely based on previous year topics. We will cover the previous year topics, the important highlights for the previous year topics that will be covered, and some images will be covered in this session. So this is a short session, sort of rapid revision for the INICET examination. Okay. Now see, all of you know that X-shape graph. When it is X-shape, it is a graph of competitive inhibition. And what is worth to remember here? So see, in the competitive inhibition, the Km value, the Km means Michaelis Menten constant, it is increased in the Km in presence of inhibitor. It is increased. So it is substrate concentration. What is Km? Substrate concentration to produce half of the maximum velocity. So this is -1 by Km. This is Lineweaver-Burke plot or double reciprocal plot, which is X shape. That means it is a graph of competitive inhibition. Here inhibitor is similar to the substrate, so they compete for the active site of an enzyme molecule. So in this type of inhibition, Km increases and Vmax remains same. Vmax remains same. Now see, in any type of inhibition, Vmax will remain either it is unaffected or it is lowered. Either it is unaffected or it gets lowered. Vmax means maximum velocity. And see, this is a inhibition. This is inhibition. So in any type of inhibition, either it remains same means unaffected or it gets lowered. Vmax. So अगर ऑप्शन में Vmax इंक्रीज हुआ, ऐसा अगर ऑप्शन है तो उसको पहले स्ट्राइक आउट करो कि वो ऑप्शन, वो आंसर नहीं रहेगा, क्योंकि ये इनिबिशन है, इसमें मैक्सिमम वेलोसिटी या तो सेम रहेगी या तो डिक्रीज होगी. ठीक है, तो ये पॉइंट हमको याद रखना है. तो इससे हमारे एक दो ऑप्शंस चले जाएंगे. तो Vmax remains same and Km increases in the competitive inhibition. So this is a Lineweaver-Burke plot or double reciprocal plot in competitive inhibition. Now there are number of examples for competitive inhibition which are used as a therapeutic agent in the treatment. For example, see this dicumarol or warfarin. These are oral anticoagulant, and this topic is integrated with pharmacology. So there is a chance of question on this topic. It is related with vitamin K. It is related with the competitive inhibition. It is related with these drugs. So it is connected with pharmacology. And also there is post-translational gamma carboxylation. Post-translational gamma carboxylation. So this is post-translational modification. So this comes under genetic also. So this is overlapping topic between different topics or different areas also in between the subject. So there is chance of getting question on this topic. So dicumarol or warfarin, these are oral anticoagulant. So they are used in the treatment, dicumarol and warfarin, and they inhibit the enzyme vitamin K epoxide reductase. This is Z, this is dicumarol or warfarin. It inhibits the vitamin K epoxide reductase and prevent the conversion of oxidized vitamin K to the reduced vitamin K. So this vitamin K, this is vitamin K, role of vitamin K. Vitamin K is required for the post-translational gamma carboxylation. इसका मतलब ये होता है कि clotting factor 2, 7, 9, 10, 2, 7, 9 और 10, इसके एक्टिवेशन के लिए हमको for the activation of factor 2, 7, 9, 10 we require vitamin K. It causes gamma carboxylation of glutamate. इसमें जो ग्लूटामेट रहता है पेप्टाइड में, ये पेप्टाइड में जो ग्लूटामेट है उसमें एक कार्बोक्सिल ग्रुप अटैच रहता है गामा कार्बन को। तो ये विद द हेल्प ऑफ विटामिन के we add the second carboxyl group and we give the extra negative charge to the this clotting factor. Now this clotting factor can combine with the positively charged calcium ion. So negatively charged glutamate means gamma carboxyglutamate forms complex with the calcium and it activates the clotting factors. So this is important here. So oral anticoagulant dicumarol warfarin inhibit the drug vitamin K epoxide reductase by the competitive inhibition, and vitamin K is required for the post translational gamma carboxylation of clotting factor 2, 7, 9, 10. So this is image of gout which involves the first metatarsophalangeal joint. Gout, first metatarsophalangeal joint is most commonly involved in the gout. So in the treatment of gout we give the drug allopurinol. Allopurinol is the drug which is given in the treatment. It acts by the competitive as well as suicide inhibition. Competitive as well as suicide inhibition. Allopurinol decreases the uric acid formation. It acts on the xanthine oxidase enzyme. So in the purine nucleotide degradation, remember purine nucleotide degradation means AMP, adenosine monophosphate, guanosine monophosphate. इनके degradation में see in the purine nucleotide degradation, so IMP, inosine monophosphate, AMP, adenosine monophosphate, and the GMP, guanosine monophosphate, they are converted into hypoxanthine and xanthine, hypoxanthine, and then it is converted into xanthine, and xanthine is converted into uric acid. Xanthine is converted into uric acid. So hypoxanthine is converted into xanthine, xanthine is converted into uric acid with the help of enzyme xanthine oxidase. Xanthine oxidase. This requires molybdenum as a cofactor. Molybdenum is required for the activity of xanthine oxidase, and in this reaction there is production of H2O2, xanthine oxidase. So this enzyme, it is inhibited by two mechanisms. First, it is inhibited by allopurinol by competitive inhibition. Competitive inhibition, allopurinol inhibits the xanthine oxidase by competitive inhibition because it is structurally similar to that of hypoxanthine. And second mechanism is suicide inhibition, in which this xanthine oxidase converts this allopurinol into alloxanthine, and this alloxanthine is more powerful inhibitor of this xanthine oxidase enzyme. It is more powerful inhibitor of xanthine oxidase enzyme. So that's why it is also known as suicide inhibition. So gout, in the treatment of gout, there is a drug which is used, that is allopurinol. See, identify the enzyme X targeted by allopurinol in the given pictures. Now see, hypoxanthine is converted into xanthine, xanthine is converted into uric acid. This is purine nucleotide degradation. So here enzyme is xanthine oxidase. So enzyme X, identify the enzyme X. Here answer is xanthine oxidase. These are the various examples of competitive inhibition and therapeutic drugs which are used in the treatment. They are important or worth to remember. See, allopurinol, it inhibits the xanthine oxidase used in the treatment of gout. Then methotrexate, it is used as an anti-cancer agent. It is anti-metabolite. It inhibits the dihydrofolate reductase enzyme, and it is used in the treatment of cancer. It is structurally similar to that of folic acid. So it is used in the treatment of cancer, methotrexate and aminopterin. Okay. Then sulfonamide, it is antibiotic. It is used in the treatment of various infection. It is structurally similar to para-aminobenzoic acid. So it is a competitive inhibitor of dihydropteroate synthase. Then vitamin K, it inhibits the vitamin K epoxide reductase. And statins group of drugs, this is very, very important. Statins group of drugs, they inhibit the HMG coenzyme A reductase. They inhibit the hydroxymethylglutaryl coenzyme A reductase in the cholesterol biosynthesis. HMG coenzyme A reductase is the rate limiting enzyme in the cholesterol biosynthesis. So statin group of drug, they particularly inhibit the hydroxymethylglutaryl coenzyme A reductase. Now see, this is non-competitive inhibition, V-shaped graph. it is non-competitive inhibition. Here the inhibitor is not structurally similar to that of the substrate. So, and it attaches to the site other than active site or other than substrate binding site, and you will get V-shaped graph. This is line view or Burke plot. अगर normal graph देखोगे आप, इसका अगर आप normal graph देखोगे वो, so this is normal curve, and in presence of inhibitor the curve will be like this. So in this type of inhibition, in non-competitive inhibition, Km, it is unaffected or Km remains same, and Vmax that is lowered. Vmax decreases or Vmax lowered. So this is important part, that is what happens to Km and what happens to Vmax in different type of inhibition. And these images, X-shape, V-shape graph and parallel lines, these are important in competitive, non-competitive and uncompetitive inhibition. The example is fluoride bulb. This is fluoride bulb. It is gray cap fluoride bulb. This is known as fluoride bulb. So sodium fluoride, potassium oxalate in the 1:3 ratio, it is used for collection of blood sample for the glucose estimation. To get the true value of glucose, because if we do not collect the sample in the fluoride bulb, the value of glucose will decreases by 5 to 10 milligram per deciliter per hour. This is because of continuous glycolysis by the RBCs. Fluoride ions, they inhibit the enzyme enolase of glycolysis to prevent enolase of glycolysis. So this is answer here, enolase of the glycolysis by non-competitive irreversible inhibition. So this is fluoride bulb. This is plain tube which is used for the serum, and this is EDTA bulb. Now this is the parallel lines here. So parallel lines indicates it is uncompetitive inhibition. Here inhibitor binds with the enzyme substrate complex, and in this type of inhibition both Km and Vmax both decreases. The example is phenylalanine. Phenylalanine inhibit the placental alkaline phosphatase. Also one drug, mycophenolic acid, that inhibit the IMP dehydrogenase. Now see this. A 60-year-old man has end-stage renal disease for 5 years, and he underwent renal transplantation. The transplant surgeon started him on immunosuppressant drug to prevent graft rejection. Identify the enzyme X targeted by the drug mycophenolic acid in the picture given below. So mycophenolic acid inhibit the inosine monophosphate dehydrogenase that converts the inosine monophosphate into xanthosine monophosphate. This is a uncompetitive inhibitor of this enzyme, IMP dehydrogenase. Uncompetitive inhibitor of IMP dehydrogenase. In uncompetitive inhibition, inhibitor attached to the enzyme substrate complex and lowers both. It decreases the Km value, it decreases the Vmax. Now the glucose transporter, the most important topic, glucose transporters. This is frequently asked topic in the INICET NEET PG entrance examination. This is or also FMG examination. This is frequently asked topic. So remember only 5 important glucose transporters, and this is a type of facilitated diffusion. Facilitated diffusion means it requires carrier protein. In the facilitated diffusion, it requires carrier protein. Energy is not required. It is down the concentration gradient, means from higher concentration to lower concentration. So these belongs to facilitated diffusion. They follow the ping pong mechanism and they follow the saturation kinetic. As it is carrier protein dependent, they follow the saturation kinetic like enzymes. मतलब hyperbolic curve मिलेगी saturation kinetic. Simple diffusion जो है, passive diffusion जो रहता, in case of simple diffusion, the rate, it is the straight line. It is a straight line. It will not follow the saturation kinetic, but the carrier dependent transport will follow the saturation kinetic. For example, active transport, secondary active transport, or also the facilitated diffusion. They will show the saturation kinetic as shown by the enzyme. So glucose transporter. Now what are the points important to remember from this chart? See, GLUT4, this is important because these are the insulin dependent glucose transporter and their location is important, that is skeletal muscle, heart and adipose tissue. So this point is very, very important to remember. GLUT4, GLUT8 and GLUT12, they are insulin dependent glucose transporter. But remember the location of GLUT4, they are present in the skeletal muscle, heart and adipose tissue and they are insulin dependent. They are insulin dependent. Also GLUT8 and 12, they are also insulin dependent. So this is worth to remember. This point is very, very important from this chart. And second important point from this chart, see the location of GLUT1, it is widely distributed. GLUT1, it is present in the brain, kidney, colon, placenta, RBCs and retina. Remember, Kohli plays for RBC nahi, RCB. Kohli plays for RCBs. So Kohli means kidney, plays placenta, for RCB means RBCs, colon, brain. So remember these points. It is widely distributed, GLUT1, and it is important for basal glucose uptake. It is important for basal glucose uptake. And point to remember, in the GLUT2, it is important for the regulation of blood glucose level because it is present in the liver sinusoidal surface. It is present in the beta cells of the pancreas and important in the release of insulin. Third important point, it is present in the basolateral surface of the intestine. Also, it is present on the basolateral surface of renal tubular cell. So, it is important for the glucose regulation. GLUT2. GLUT3, it is present in the neuron. GLUT5, remember 5, facilitated diffusion, fructose. It is required for the fructose, facilitated diffusion, GLUT5, FFF. So this is important. So these are the important points to remember in the glucose transporter. These are the types of facilitated diffusion. Remember this. These are the types of facilitated diffusion. It is carrier mediated transport. What do you mean by carrier mediated transport? Just wait. Now see, this is a graph. Okay. And this is percent maximum on y-axis and this is the level, this concentration. This is concentration and this is percent maximum rate of absorption. So in case of simple diffusion, you will get straight line. So it is not carrier mediated transport, it is simple diffusion. But in case of carrier mediated transport, carrier mediated मतलब कौन कौन से? Facilitated diffusion, active transport and passive active transport means primary active and secondary active transport. In this case you will get this type of curve, like enzymes. Okay, it will give saturable kinetics. So further increasing substrate concentration will not increase the absorption rate. This is shown by the carrier mediated transport. So carrier mediated transport कौन कौन से है? Mediated transport, it includes the facilitated diffusion and active transport. Primary active, secondary active transport. So this graph is important to remember. So saturation kinetics shown by the facilitated diffusion and active transport, while the straight line, it is shown by the simple diffusion. So this graph is important. Also facilitated diffusion shows the ping pong mechanism. It shows the ping pong mechanism. In glucose absorption, which one is important for the absorption of glucose? That is SGLT1. These transporters are important. Sodium dependent glucose transporters, they are important in the glucose transport and it is a type of secondary active transport. So remember this diagram in the mind. Just wait. Remember this diagram in the mind. Suppose this is intestinal cell. This is apical side. So keep this diagram in the mind. So sodium, along with the sodium, glucose, galactose and amino acid, they are absorbed. So this is known as SGLT, sodium dependent glucose transporter. Along with the sodium, glucose absorbed in the intestinal cell. And for to move this sodium out, the sodium potassium pump is required, which moves 3 sodium out, of the cell in exchange of the potassium, and for this ATP is required. So this is primary active transport, and here direct energy is required, but here indirect utilization of energy is required, so that's why it is secondary active transport. And the GLUT5 GLUT, this is SGLT, sodium dependent glucose transporter. This is only glucose transporter. This is a type of facilitated diffusion. So fructose is via the GLUT5. So this is fructose. Okay, and glucose enters into the circulation via GLUT2, GLUT2, glucose transporter 2. Glucose into the blood, it is absorbed into the circulation from the intestinal cell via the GLUT2. So remember this diagram, SGLT, sodium dependent glucose transporter, is required. It is a secondary active transport. It is required for the absorption of glucose. GLUT5 is for the fructose, and GLUT2, it is present on the basolateral surface. It is required for absorption of glucose from intestinal cell into the blood, GLUT2. Okay, so don't confuse between SGLT and GLUT1. SGLT1 and GLUT1. SGLT is the sodium dependent glucose transporter. It is a type of secondary active transport. It is important for the transport of glucose and galactose from the renal tubular cell, from the intestinal cell. And SGLT2, it is present in the renal tubular cell. Now coming to the next important topic, that is glycosaminoglycans or mucopolysaccharides. These are polyanions. Glycosaminoglycans or mucopolysaccharides. These are the polyanions. They bears negatively charged groups, carboxyl group, acetyl group, sulfate groups. These are negatively charged group, and because of negative groups, they repulse from each other. So they are mucus in nature. They have repelling action on each other. So they are mucus in nature. They are shock absorbent. They are lubricant. They are shock absorbent. These mucopolysaccharides are glycosaminoglycan. So see, remember 6 important mucopolysaccharide. The point to remember in the hyaluronic acid is this glycosaminoglycan does not contain sulfate group. It is present in the synovial fluid and vitreous humor of the eye. It acts as a lubricant, shock absorbent, and it is important in the wound repair. Apart from the vitamin C, which is required for the wound repair, and zinc. Vitamin C is required for the wound repair. Zinc is required for the wound repair. Also the hyaluronic acid is required for the wound repair. It is important in cell migration and wound repair. Remember the functions of hyaluronic acid. Then chondroitin sulfate. It is present in the cartilage bone tendon. See, those who started with the H, जिनका नाम H से start होता है, that they contain N-acetyl glucosamine. जिनका नाम H से चालू होता है, जैसे hyaluronic acid है, हिपेरिन है, हिपेरन सल्फेट है. They contain N-acetyl glucosamine. They are repeating disaccharide. ये जो रहते हैं ना म्यूकोपॉलीसैकेराइड, दे आर रिपीटिंग डाइसैकेराइड. रिपीटिंग डाइसैकेराइड मतलब क्या रहेगा? रिपीटिंग डाइसैकेराइड मतलब, सी, इन द glycosaminoglycan, they are repeating disaccharide. They are composed of uronic acid and amino sugar and uronic acid. So repeating amino sugar, uronic acid. So amino sugar can be of two type, that is N-acetyl glucosamine or galactosamine. N-acetyl galactosamine. And uronic acid is of two type. One is in all there is D-glucuronic acid, and in some it contain L-iduronic acid. So try to remember this part. हर इसमें एक अमाइनो शुगर रहेगा और यूरोनिक एसिड रहेगा. एक इस दो में से एक अमाइनो शुगर रहेगा और दो में से एक यूरोनिक एसिड रहेगा, जिसका नाम H से चालू होता है, जैसे हाइलोरोनिक एसिड, हिपेरिन, और heparan sulfate, they will contain N-acetyl glucosamine. केराटन सल्फेट का कंपोजिशन कंप्लीट अलग है, तो केराटन सल्फेट को इसमें पकड़ने का नहीं. तो they contain N-acetyl glucosamine and D-glucuronic acid. Most of the glycon contain D-glucuronic acid except dermatan sulfate which contain L-iduronic acid. Also heparin, it contain L-iduronic acid. And the केराटन सल्फेट का कंपोजिशन ही अलग है. केराटन सल्फेट कंटेन एन एसिटिल ग्लूकोजामाइन एंड गैलेक्टोज. एन एसिटिल ग्लूकोजामाइन एंड गैलेक्टोज. नाउ सी दिस टेबल. Hyaluronic acid, N-acetyl glucosamine, D-glucuronic acid. This is the composition. It is important in wound repair, cell migration, lubricant, and shock absorbent. Hyaluronic acid. Chondroitin sulfate, it is present in cartilage, bone, tendon. So this is C, not started with the H, so it is N-acetyl galactosamine, and this is chondroitin sulfate, so here the D-glucuronic acid is present. So all contain D-glucuronic acid except dermatan sulfate which contain L-iduronic acid. Also heparin contain L-iduronic acid, and keratin sulfate, it does not contain any uronic acid. It contain N-acetyl glucosamine plus galactose. Okay, so chondroitin sulfate, cartilage, bone and tendon, it is important for shape and structure, and along with the hyaluronic acid, this point is very, very important. So because these points are directly from the Harper, that's why they are important and frequently asked. So compressibility of the cartilage, in weight bearing with hyaluronic acid, this is a function of chondroitin sulfate. This is a function of chondroitin sulfate. Then third is the dermatan sulfate, it is present in skin. Dermatan sulfate, it is present in skin, heart valves, sclera. The composition is dermatan sulfate, N-acetyl galactosamine plus L-iduronic acid. Dermatan sulfate contain L-iduronic acid, and it is present in skin walls and sclera, important in maintaining the shape and structure of these tissues. Then heparin, it contain N-acetyl glucosamine and L-iduronic acid, predominantly L-iduronic acid, also contain D-glucuronic acid. Heparin is an anticoagulant, and it is the only not present intracellularly, but in some cells it is present intracellularly also. The main function of heparin is anticoagulant. It acts as an anticoagulant. It is responsible for release of lipoprotein lipase enzyme from the capillary endothelium. Release of lipoprotein lipase from capillary endothelium. Heparan sulfate, इसके function important है. ये part आपको याद रखना है. This part is very, very important of heparan sulfate. Heparan sulfate, N-acetyl glucosamine plus D-glucuronic acid, also L-iduronic acid, but this is predominant here. In heparin, the L-iduronic acid is predominant. So it is present in the basement membrane. It is present in the capillary endothelium, it is present in the synaptic vesicles. Basement membrane, capillary endothelium, synaptic vesicle. ये सारे चार्ट्स जो है ना वो हार्पर में से पढ़ने हैं आपको, क्योंकि हार्पर का जो जैसे का वैसा क्वेश्चन आता है एग्जाम में. बेसमेंट मेम्ब्रेन, capillary endothelium, synaptic vesicle. Three important functions of this heparan sulfate. Three important functions. The first one is the negative charge, means charge selective barrier of glomerular basement membrane is because of the negative charge of this heparan sulfate. Charge selective barrier. आपको पता है ना, albumin does not crosses the glomerular filtration barrier because of negatively charged. So negatively charged compound there is the heparan sulfate. So charge selectiveness of glomerular basement membrane is because of heparan sulfate. Second important, it is required for attachment of lipoprotein lipase to the capillary endothelium. Second important function, attachment of lipoprotein lipase to the capillary endothelium. ये attachment के लिए लगता है, ये release के लिए लगता है heparin. Third important, it acts as a receptor. It acts as a receptor and participate in cell adhesion and cell-cell interaction. It acts as a receptor, participate in cell adhesion and cell-cell interaction. So these are the three important functions of heparan sulfate. Then keratin sulfate has complete different composition. It is N-acetyl glucosamine plus galactose. There is no uronic acid in the keratin sulfate. So keratin, its name is given from the cornea. So keratin sulfate is present in the cornea. Keratin sulfate 1. The transparency of cornea is because of keratin sulfate 1. So it is present in cornea, cartilage and connective tissue. So transparency of cornea is mainly by the keratin sulfate 1. It is keratin sulfate 1 and also dermatan sulfate. So if there is no keratin sulfate in the option, go with the dermatan sulfate. So principally it is because of keratin sulfate, but also dermatan sulfate contributes to the transparency of the cornea. Also keratin sulfate is important in the cartilage, shape of the cartilage. So these are the 6 important glycosaminoglycan. Glycosaminoglycan with no sulfate, hyaluronic acid. Glycosaminoglycan with no uronic acid is the keratin sulfate. Glycosaminoglycan repair for the cell migration and wound repair, it is hyaluronic acid. Glycosaminoglycan which is important for the transparency of cornea is the keratin sulfate 1. Glycosaminoglycan which is important for charge selectiveness of glomerular basement membrane is heparin sulfate. The anticoagulant function is of heparin. Anticoagulant function is of heparin. Now these are the mucopolysaccharidosis, the disorders related with degradation of glycosaminoglycans. It is known as mucopolysaccharidosis. What is worth to remember in the mucopolysaccharidosis is MPS, mucopolysaccharidosis 1H, MPS 2 and MPS 1S, this Shy disease. Okay, Hurler syndrome, Shy disease and Hunter syndrome. These are 3 important. Remember these 3 क्योंकि बाकी के सब याद किए तो भी हमको जब तक हम एग्जाम के पहले नहीं पढ़ेंगे तब तक वो हमको याद नहीं रहेगा. तो प्रिंसिपली रिमेंबर हर्लर as she is always first. Remember, she is always first, so hurler is the first. And in hurler there is corneal clouding. Remember this point, there is corneal clouding in the Hurler syndrome. Corneal clouding is there in the Hurler syndrome. These are the multi-system involvement disorders which are characterized by mental retardation. There is skeletal abnormality, hepatosplenomegaly, coarse facies, keen lesions are there. So multi-system involvement is there in this mucopolysaccharidosis. Only some points to remember about this. This is because of deficiency of iduronidase enzyme, and Hunter syndrome, it is because of iduronate sulfatase. It is because of iduronate sulfatase. This is iduronidase, this is iduronate sulfatase. And the only feature which is not present in the Hunter and present in the Hurler is no corneal clouding. There is no corneal clouding in the Hunter syndrome. Remember, Hunter requires clear vision फॉर द हंटिंग. उसको शिकार करने के लिए उसकी विजन क्लियर होना. इतना याद रखो कि इसमें कॉर्नियल क्लाउडिंग नहीं रहती, लेकिन रेटाइनल प्रॉब्लम तो रहती ही है, लेकिन कॉर्नियल क्लाउडिंग इसमें नहीं रहती. सो दिस इज ओनली द डिफरेंशिएटिंग फीचर. रेस्ट ऑफ द फीचर्स आर नियर अबाउट सेम, एंड दीज आर ड्यू टू there is defect in the degradation of dermatan sulfate and heparin sulfate. So dermatan sulfate and heparin sulfate accumulates in these disorders in the various tissues, and that causes multi-system involvement. So remember only 2, that is Hurler, Hunter, and also Shy disease. It is because of iduronidase, partial deficiency of iduronidase, and the symptoms are as Hurler syndrome but less severe, and as there is no heparin sulfate accumulation, there is no mental retardation. Remember this, whenever there is heparin sulfate accumulation, it causes mental retardation. So these 2, remember these 2 disorders. There are others also. So see, Hurler syndrome, iduronidase, Hunter, iduronate sulfatase. All symptoms are near about same. There is corneal clouding in the Hurler syndrome and no corneal clouding in the Hunter syndrome. These are the other, that is Sanfilippo, Marchio, Moretti-Lamy, Sly disease. These are the other mucopolysaccharidosis. Now the important topic which is frequently asked in the examination, glycogen storage disorders. Glycogen storage disorders. There is accumulation of glycogen, so that's why they are known as glycogen storage disorders, and these are related with the glycogenesis and glycogenolysis. Here one important question is also frequently asked, that is direct and indirect activator of glycogen phosphorylase, that is calcium. Remember, calcium is the direct as well as indirect activator of glycogen phosphorylase. So calcium will promote glycogenolysis, degradation of glycogen. So in glycogen storage disorder, remember from type 0. Now 0 is also important क्योंकि पिछले बार इस पे क्वेश्चन आके गया. तो टाइप 0 इज ऑल्सो important. So it is glycogen synthase defect. type 0, and early death occur in the type 0. So there is no hepatomegaly in the type 0, no hepatomegaly. Hypoglycemia is there in between meal, and early death occurs because of defect in glycogen synthase. Because of defect in glycogen synthase, which is main important enzyme or rate limiting enzyme in the glycogenesis. And glycogen synthase, it is active in the dephosphorylated state, which is by the insulin. Remember, 4 important hormones that are active in the dephosphorylated state. 4 important hormones that are active in the dephosphorylated state. So in the dephosphorylated state, which is favored by the insulin, 4 important hormones, they are not 4, there is a list, but remember these 4. Okay, so glycogen synthase, which is important. Glycogen synthase, it is important in the glycogenesis. Then pyruvate dehydrogenase complex, which is important in the link reaction, that is conversion of pyruvate to acetyl coenzyme A. Then acetyl coenzyme A carboxylase. This is rate limiting enzyme in the fatty acid synthesis. Acetyl coenzyme A carboxylase. Then enzymes of glycolysis, glycolytic glycolysis enzyme, and the hydroxymethylglutaryl coenzyme A reductase. Cholesterol biosynthesis, rate limiting enzyme in the cholesterol biosynthesis. So remember, these enzymes, they are active in the dephosphorylated state. This is very, very important to remember. And important points: glycogen synthase, pyruvate dehydrogenase complex, acetyl coenzyme A carboxylase, glycolysis, and HMG coenzyme A reductase. They are active in the dephosphorylated state, and dephosphorylated state, it is favored by the insulin. In the well-fed state, there is release of insulin that will promote the glycogenesis, that will promote the fatty acid synthesis, that will promote the cholesterol synthesis. Now the enzymes which are active in the phosphorylated state. So this is covalent modification, phosphorylation or dephosphorylation. This is covalent modification in the enzyme activity or regulation of enzyme activity. In the phosphorylated state, the enzymes which are active, that includes glycogen phosphorylase, then phosphorylase kinase, citrate lyase, gluconeogenesis enzymes, that is pyruvate carboxylase, phosphoenol pyruvate carboxykinase, glucose 6 phosphatase, and all. So these are active in the phosphorylated state. Also the hormone sensitive lipase, it is active in the phosphorylated state. So this is favored by the glucagon. So remember these enzymes. There is one table on which it is written the enzymes which are active in the dephosphorylated state and which are active in the phosphorylated state from the Harper. So remember these four important examples of dephosphorylated state and the phosphorylated state. Dephosphorylated state, it is maintained by the insulin, while phosphorylated state, it is maintained by the glucagon. Okay. Now, Von-Gogg's disease. Typically, Von-Gogg's disease, you may get a case or clinical scenario on the Von-Gogg's disease. This is a glycogen storage disorder type 1A. Glycogen storage disorder type 1A. It is because of defect in glucose 6 phosphatase. There is no spleen involvement, no muscle involvement. This enzyme is absent in the muscle. So there is no muscle involvement. Also, there is no spleen involvement in this disease. There is hepatoreinomegaly. Reno matlab kidney. Hepatoreinomegaly in this disorder. Apart from the hepatoreinomegaly, there is blood picture which shows lactic acidosis, which show lactic acidosis. Increased uric acid is there because of diversion of glucose 6 phosphate towards the HMP shunt. That's why HMP shunt will generate the ribose, and ribose is the starting material for purine nucleotide synthesis. So there is hyperuricemia, there is hyperlipidemia, and fasting hypoglycemia. When liver is involved in the hepatic glycogen storage disorder, there is fasting hypoglycemia. So fasting hypoglycemia, hyperlipidemia because glucose 6 phosphate is diverted for the uric acid synthesis, hyperuricemia, lactic acidosis, and there is hepatomegaly. Remember, there is no spleen involvement and no muscle involvement in this disorder. In this disease, no muscle involvement in the glycogens in the von Gog's disease, type 1A. Type 1B, it is due to glucose transporter defect in the endoplasmic reticulum. It is characterized by recurrent infection, neutropenia and recurrent infection in addition to these symptoms. Neutropenia and recurrent bacterial infection in the type 1B, in the type 1B glycogen storage disorder. Then type 2, it is a Pompe's disease. There is liver involvement, there is muscle involvement in the Pompe's disease, and principally there is involvement of heart in the form of cardiomyopathy, and death of the child occurs in the 18 months to 2 years of the age. So glycogen accumulation in liver, heart, and muscle, and death at early age due to the heart failure because of cardiomyopathy, Pompe's disease. This is due to defect in lysosomal acid maltase. Lysosomal acid maltase. Then Cory's disease. Remember here A, B, C, D. A, B, C, D. Anderson disease, branching enzyme. Cory's disease, debranching enzyme. A, B, C, D. Anderson's disease. This is Anderson disease or amylopectinosis. There is defect in the branching enzyme. Cory's disease, also known as limited dextrinosis or Forbes disease. Cory's disease, limited dextrinosis or Forbes disease, there is debranching enzyme defect. Okay, and in these both there is muscle involvement, also liver involvement. Principally there is liver involvement, and there is increase in the SGOT and SGPT level. There is progressive liver cirrhosis. In both there is progressive liver cirrhosis, and there is increase in the SGOT and SGPT level in type 3 and type 4 glycogen storage disorder. There is muscle involvement also in this disorder. McArdle disease, this is important. After the von Gog's and Pompe's disease, this is third one, which is very, very important. McArdle disease, it is due to defect in the enzyme muscle glycogen phosphorylase. Muscle glycogen phosphorylase, and it is characterized by exercise intolerance. It is characterized by exercise intolerance. And accumulation of glycogen in the muscle. It is also characterized by second wind phenomenon, that is if you take a pause, or if you take a rest for some time, you can resume your activity. So that is known as second wind phenomenon. And if you continue to do your exercise or activity, there is myoglobinuria because of rhabdomyolysis and passage of burgundy color urine in this McArdle disease. So exercise intolerance is there, and this is a typical feature, and you may get question on this exercise intolerance. So defect in muscle glycogen phosphorylase, McArdle's disease. And the sixth one is the Her's disease due to liver phosphorylase defect. Her's disease, liver phosphorylase defect, and there is hepatomegaly and fasting hypoglycemia. So here the diseases which are important for the exam is von Gog's disease, hepatorenal is there, doll-like faces, hepatorenal, hyperlipidemia, hyperuricemia, fasting hypoglycemia, lactic acidosis. This is important. Von Gog's disease. Second important is the Pompe's disease, where heart involvement is there and cardiomyopathy is there, but death at early age occurs in the Pompe's disease due to defect in the lysosomal acid maltase. And McArdle disease, third one, exercise intolerance, second wind phenomenon, and myoglobinuria. Okay, if exercise intolerance along with the hemolysis is there, RBC hemolysis is there, it indicates the phosphofructokinase defect. It indicates phosphofructokinase defect. Now coming to the next topic, that is pyruvate dehydrogenase complex or linked reaction. Pyruvate dehydrogenase, it is a multi-enzyme complex composed of three enzymes, that is E1, E2 and E3, and 5 coenzymes. So it is also a important question pyruvate dehydrogenase complex. 5 coenzymes includes B1, B2, B3, B5 and lipoic acid. Lipoic acid. B1 means NAD, B2 means FAD coenzyme form. Sorry, B1 is thymine pyrophosphate, B3 is NAD, B5 is coenzyme A. So these are the 5 important coenzymes required for the pyruvate dehydrogenase complex, alpha ketoglutarate dehydrogenase complex, and also for the branch chain keto acid dehydrogenase complex. तो रिमेंबर दिस 3 एंजाइम्स एंड 5 कोएंजाइम्स. 3 एंजाइम्स कौन कौन से है, इस पे क्वेश्चन आता है. E1 अभी एक एग्जाम में पूछा गया कि E2 कौन सा है, तो अगले एग्जाम में पूछेंगे कि E1 कौन सा है, या उसके अगले एग्जाम में पूछेंगे E3 कौन सा है. ठीक है. सो हियर E1 इज पायरुवेट डिहाइड्रोजनेज इटसेल्फ, पायरुवेट डिहाइड्रोजनेज इटसेल्फ. E2 is dihydrolipoyl trans-acetylase and E3 is dihydrolipoyl dehydrogenase. E1 is pyruvate dehydrogenase, E2 is dihydrolipoyl trans-acetylase and E3 is dihydrolipoyl dehydrogenase. See, here pyruvate is converted into hydroxyethyl thymine pyrophosphate, which donates this group to the lipomide, and there is formation of acetyl lipomide, and from this acetyl group is converted into acetyl coenzyme A, and there is formation of reduced lipomide, and in this reaction FAD is converted into FADH2 and NAD is converted into NADH. This NADH will enters into the electron transport chain and will give 2.5 ATPs. So this is pyruvate dehydrogenase complex. E1 pyruvate dehydrogenase itself, E2 dihydrolipoyl transacetylase, and E3 is the dihydrolipoyl dehydrogenase. These are the 5 coenzymes: thymine pyrophosphate, FAD, NAD, coenzyme A and lipoic acid. इसके जैसे और 2 कौन से एंजाइम्स है, अल्फा कीटोग्लूटारेट डिहाइड्रोजनेस कॉम्प्लेक्स ऑफ द TCA cycle and branch chain keto acid dehydrogenase complex, which is important for the metabolism of branch chain amino acid, that is valine, leucine, isoleucine. Now coming to the electron transport chain and oxidative phosphorylation. From this topic, the important one to remember, or important points to remember, is the different inhibitors and uncouplers. Inhibitors and uncouplers. Now the electron flows from the complex 1 to the coenzyme Q, from coenzyme Q to the complex 3, complex 3 to cytochrome C, cytochrome C to complex 4, where it is accepted by the oxygen molecule and it will form the water molecule. So oxygen is converted into water molecule. This is from the NADH. This is from the NADH. So NADH will be generated in different metabolic pathways. It is generated in different metabolic pathway. For example, glycolysis, TCA cycle, fatty acids in beta oxidation of fatty acid. In this pathway, there is generation of NADH or generation of reducing equivalents. While from the complex 2, means succinate dehydrogenase complex, it is transferred to the coenzyme Q. From coenzyme Q to the complex 3 to cytochrome C and to complex 4, and finally accepted by the oxygen and reduced to form water molecule. Now here remember, these are the mobile carriers, coenzyme Q and the cytochrome C. This is protein and mobile carrier. This is lipid in nature, ubiquinone. It is with isoprenoid side chain, so it is ubiquinone. It is lipid in nature and mobile. These are the mobile units. Coenzyme Q and cytochrome C. And these are the various complexes, 1, 2, 3, 4 complex, and this is the 5th one, that is ATP synthase, which is responsible for the ATP synthesis. Okay. Now through the, whenever there is transport of electron, when the electron is transferred from this reducing equivalent through the various complexes, there is simultaneous pumping of protons. इसके दो functions है ये complex के, कि during the transfer of electron, simultaneously there is pumping of protons into the intermembrane space, and which is important, there is generation of proton gradient. जैसे हमने बोला, जैसे पानी से इलेक्ट्रिसिटी बनाते हैं, तो पानी से इलेक्ट्रिसिटी बनाते वक्त पानी को एक ऊपर के लेवल पे लेके जाते और ऊपर के फ्लो से नीचे छोड़ते, ताकि वो टरबाइन घूमे और वो ट्रांसफार्मर के थ्रू इलेक्ट्रिसिटी जनरेट हो. Same principle is here. There is continuous pumping of proton, 4 protons from the complex 1, 4 protons from the complex 3, and 2 protons from the complex 4. So there is during the transfer of electron, there is pumping of 10 protons into the intermembrane space. 10 protons into the intermembrane space during the transfer of one electron. So as 10 protons are pumped out from complex 1, complex 3 and complex 4, not from the complex 2, because energy generated during the movement of electron from this complex is very low, and also second important point is it is not a transmembrane protein. These are the transmembrane, these complexes are transmembrane, this is not transmembrane. It does not span the membrane completely, but principal reason is the energy generated during the transfer of electron through this complex is very low. Okay, that's why it is unable to pump the proton into the intermembrane space. So once the protons are pumped into the intermembrane space, there is generation of proton gradient. जैसे मतलब पानी को एक जगह पे हमने जमा किया. So this is proton gradient, and there is no, this membrane is impermeable. This is not permeable to any ions. So only exit point for this ions is through the FO complex. So this is FO complex of ATP synthase. और यहां से जब ये प्रोटॉन्स मैट्रिक्स में आएंगे तो आते आते ये गैमा हैंडल को रोटेट करेंगे, F1 यूनिट के गैमा हैंडल को रोटेट करेंगे. दैट कॉजेस कन्फर्मेशनल चेंज इन द बीटा सब यूनिट दैट कॉजेस एटीपी सिंथेसिस. सो दैट्स व्हाई इट इज नोन एज वर्ल्ड स्मॉलेस्ट मॉलिक्यूलर मोटर. It is also known as world's smallest molecular motor, complex 5 of electron transport chain. Now, what are the important points to remember here? The various inhibitors. You may get MCQ on any any inhibitors, but this one is very, very important. Complex 4, inhibitors of complex 4. These include gases: cyanide, carbon monoxide, hydrogen sulfide, azide. Cyanide, carbon monoxide, hydrogen sulfide, azide. Just wait. Okay. So cyanide, carbon monoxide, hydrogen sulfide, azide, they inhibit the complex 4 of electron transport chain. Now the complex 1, so pairs pyridine, amobarbitol, rotenone, secobarbitol, barbiturates. Amobarbital means barbiturates. So these are the inhibitors which inhibit the complex 1 of electron transport chain and inhibit the movement of electron from complex 1 to the coenzyme Q. Malonate inhibit the succinate dehydrogenase. It is a competitive inhibitor. While all other inhibitors, they are irreversible non-competitive inhibitors. This one is the competitive inhibitor, malonate. This TTFA, this molecule and carboxyl, TTFA and the carboxyl inhibit the movement of electron from complex 2 to the coenzyme Q. Then BAL, that is British anti-lewisite, antimycin and fenformin. This inhibits the complex 3 of electron transport chain. Okay, so pyridine, amobarbitol, rotenone, they inhibit the movement of electron from complex 1 to coenzyme Q. Malonate inhibit the succinate dehydrogenase. TTFA and carboxyl inhibit the movement of electron from complex 2 to coenzyme Q. British anti-lewisite, antimycin and fenformin inhibit the complex 3. Cyanide, carbon monoxide, hydrogen sulfide and azide inhibit the complex 4 of electron transport chain. So this is a chart, and this is important table to remember. See, ATP ADP transporter, ADP transporter, which is important for movement of ATP and ADP. So this is inhibited by the attractyloside. This is a inhibitor of oxidative phosphorylation. Attractyloside. ATP ADP translocase or ATP ADP transporter, which is inhibited by attractyloside. The FO unit of the ATP synthase, it is inhibited. O for oligomycin. It is inhibited by oligomycin and venturicidin. Okay. Then F1 subunit of electron transport, F1 subunit of ATP synthase, that is complex 5 of electron transport chain, it is inhibited by orovertin. Then uncouplers क्या करते हैं, जैसे ये डायग्राम देखो, ये जो डायग्राम है इसमें क्या हो रहा है कि प्रोटॉन्स आर पम्प्ड आउट इनटू द इंटरमेम्ब्रेन स्पेस एंड दैट डेवलप्स द ग्रेडियंट, मींस पॉजिटिव आउटसाइड एंड नेगेटिव इनसाइड, because this membrane is impermeable. What is the role of uncoupler? Uncoupler increases the permeability of this membrane एंड डिसरप्ट द ग्रेडियंट। अभी परमेबिलिटी अगर इंक्रीज हो गई तो ये प्रोटॉन ग्रेडियंट डेवलप ही नहीं होगा, ये प्रोटॉन्स कहीं से भी मूव होंगे। So that delinks the electron transport chain from oxidative phosphorylation. So these molecules are known as uncouplers. So there are physiological uncouplers and the chemical uncouplers. So remember, these are the chemical uncouplers, that is 2,4-dinitrophenol, dinitropresol, fluorochlorocarbonyl phenylhydrazine, and aspirin in high doses. These are the chemical uncouplers. While thermogenin, which is important in hibernating animals, thermogenin also in the newborn babies. Thermogenin is important, thyroxine, long chain fatty acid, and unconjugated bilirubin. That's why the unconjugated bilirubin causes carnic terrors when it goes below above the 20 milligram per deciliter. It crosses the blood brain barrier and causes the toxic effect. It decreases the ATP synthesis in the brain. So physiological uncouplers are there: thermogenin, thyroxine, long chain free fatty acids, and unconjugated bilirubin. These are the chemical uncouplers: 2,4-dinitrophenol, dinitropresol, FCCP, and aspirin. And these are the ionophores, potassium ionophores. They increases the movement of potassium ions, so disrupt the proton gradient across the membrane. That includes valinomycin, gramicidin, and nigricin. Okay, valinomycin, gramicidin, and nigricin. This table is very, very important to remember. So remember this table. So these atractyloside, oligomycin, venturicidin, these are the inhibitors of oxidative phosphorylation. F1 unit, orovatin inhibit the F1 subunit. These are the chemical uncouplers, physiological uncoupler. Uncoupler मतलब जो मेम्ब्रेन की परमेबिलिटी बढ़ाता है और प्रोटॉन ग्रेडियंट डेवलप नहीं होने देता, ठीक है. एंड आइनोफोर्स, these are the potassium ions or ionophores, causes the movement of potassium ions across the membrane, so they also causes the disruption of the proton gradient. Now coming to the porphyrias, hemoglobin metabolism, porphyrias. There are many types of porphyrias. They are known as hepatic porphyrias and the erythropoietic porphyrias. Hepatic porphyrias and erythropoietic porphyrias that mainly include acute intermittent porphyria, porphyria cutanea tarda, hereditary coproporphyria, variegate porphyria, congenital erythropoietic porphyria, and erythropoietic protoporphyria. These are the important porphyrias. So hepatic porphyria, when the defect in the hepatic synthesis, because the heme synthesis occurs in the erythroid precursor cells and the liver. When there is damage, when there is defect in the hepatic heme synthesis, it causes hepatic porphyria. When it is erythroid precursor cell, it causes erythropoietic porphyria. Remember, acute intermittent porphyria, when the defect is before the uroporphyrinogen synthesis. When it is before the uroporphyrinogen synthesis, it causes abdominal pain and neuropsychiatric manifestation, and as in case of acute intermittent porphyria, abdominal pain and neuropsychiatric symptoms when it is before the uroporphyrinogen synthesis. Once there is uroporphyrinogen synthesis occurs, these uroporphyrins, they are converted into the porphyrins, and porphyrins generate the reactive oxygen species that damages the lysosomes, and release of lysosomal enzymes occurs that causes photosensitivity or cutaneous skin lesions. So after the synthesis of uroporphyrinogen, there is photosensitivity. So photosensitivity is there in the porphyria cutanea tarda. There is hereditary coproporphyria, variegate porphyria, and congenital erythropoietic porphyria. So all other having the photosensitivity except acute intermittent porphyria, because it is before the block, means before the synthesis of uroporphyrinogen. So here in acute intermittent porphyria, abdominal pain and neuropsychiatric manifestation and defective enzyme is uroporphyrinogen 1 synthase, also known as hydroxymethylbilane synthase or porphobilinogen deaminase. Porphobilinogen deaminase causes the disease is acute intermittent porphyria. These are the enzyme defects. This is the name of same enzyme, uroporphyrinogen 1 synthase or hydroxymethylbilin synthase or porphobilinogen deaminase. Then porphyria cutanea tarda, which is most common, and there is blistering skin lesion, bullous skin lesion in the porphyria cutanea tarda. It is because of uroporphyrinogen decarboxylase defect. Because of uroporphyrinogen decarboxylase defect. Then hereditary and variegate porphyria, they all three symptoms are there: abdominal pain, neuropsychiatric manifestation, and photosensitivity. While in congenital erythropoietic porphyria, this is autosomal recessive disorder. And congenital erythropoietic porphyria, it is due to uroporphyrinogen co-synthase defect. It is due to co-synthase defect, and there is photosensitivity. There is photosensitivity. There is erythrodontia, means the wood lamp examination of teeth will show the fluorescent teeth, means red fluorescence, erythrodontia, red fluorescence. Also, there is passage of red color urine in the congenital erythropoietic porphyria. In this porphyria, there is repeated skin lesions that causes scarring. Also, there is facial hairs. So, facial hairs and scarring, repeated scarring gives the werewolf-like appearance. It gives the werewolf-like appearance because of photosensitivity. So, in congenital erythropoietic porphyria, so it looks like werewolf because of repeated scarring. There is passage of red color urine because porphyrins are excited at the 400 nanometer. So, and because of generation of reactive oxygen species, it causes damage to the lysosome and it causes photosensitivity, means skin lesions. Skin lesions. So, it is also known as Gunther's disease. It is known as Gunther's disease. There is erythrodontia and red passage of red color urine. So this is congenital erythropoietic porphyria. It is autosomal recessive. And the protoporphyria, it is due to ferrochelatase or heme synthase defect. Ferrochelatase or heme synthase defect, and there is photosensitivity. So these are the different porphyrias. Now, bilirubin metabolism is also important from the hemoglobin topic. So in the bilirubin metabolism, see prehepatic, hepatic, and post-hepatic jaundice. So in prehepatic jaundice, all the parameters, all the enzyme pattern, it is normal. The enzyme levels are normal. While in hepatic jaundice, there is marked raise SGOT, SGPT level, but the obstructive enzymes, there is slightly raise in the obstructive enzyme ALP, GGT, and 5' nucleotidase. While in obstructive jaundice, this obstructive enzymes ALP, GGT, and 5' nucleotidase, there is marked increase in the activity. Now, Vandenberg reaction. Vandenberg reaction means it is a principle of bilirubin estimation. It is biphasic. Biphasic matlab it is positive, direct positive, indirect positive. That is known as biphasic. क्या होता है, जब हम रिएजेंट ऐड करते हैं तो रिएजेंट ऐड किए बराबर इमीडिएटली कलर आता है, उसको बोलते हैं डायरेक्ट पॉजिटिव. अजो बिलिरुबिन फॉर्म होने की वजह से डायरेक्ट कलर आता है, इसको बोलते हैं वैंडेनबर्ग रिएक्शन. तो जब इमीडिएटली कलर आता है उसको बोलते हैं डायरेक्ट पॉजिटिव, और वो कलर थोड़ी देर बाद, आधे घंटे बाद इंटेंसिफाई होता बिकॉज ऑफ इनडायरेक्ट बिलिरुबिन, उसको बोलते हैं इनडायरेक्ट पॉजिटिव. या तो कभी कभी डायरेक्ट बिलिरुबिन के लिए कलर ही नहीं आता, वो आधे घंटे बाद कलर आता. फॉर दैट सोलुबलाइजर इज रिक्वायर्ड. कैफीन एंड मिथेनॉल, दे आर यूज एज ए solubilizer. So in the biphasic Vandenberg reaction, means positive for both direct and indirect bilirubin, it is principally seen in the hepatitis. So there is increase in the direct bilirubin, indirect bilirubin both. So total bilirubin also increase. In the obstructive jaundice, there is increase in the direct bilirubin. While in hemolytic jaundice, there is increase in the indirect, means unconjugated bilirubin level increases. And one important point in between this is urinary urobilinogen. Early stage, it is detected by the early stage urinary urobilinogen. It is present in the hemolytic jaundice and it is absent in the obstructive jaundice. It may be present or absent in the hepatic jaundice depending upon the micro-obstruction. If a micro-obstruction is there, it is absent. So urinary urobilinogen is present in the hemolytic jaundice. And bile salt, bile pigment, they are present in the urine in patient with obstructive jaundice, also in the hepatic jaundice. Obstructive jaundice and the hepatic jaundice. Now, the congenital hyperbilirubinemia means Crigler-Najjar type 1, type 2, Gilbert, Rotor, and Dubin-Johnson syndrome. This is also important part from the bilirubin metabolism. Now see, there are unconjugated hyperbilirubinemia, means increase in the indirect bilirubin. There is increase in the indirect or unconjugated bilirubin. Indirect or unconjugated bilirubin. Here, conjugated hyperbilirubinemia means there is increase in the direct bilirubin. Direct bilirubin increases. Direct bilirubin. So total bilirubin is of direct and indirect. Direct bilirubin means conjugated bilirubin. Indirect means unconjugated bilirubin. So there are two causes of direct increase in direct bilirubin in congenital diseases. That includes Dubin-Johnson and Rotor. Remember DR, direct DR, Dubin-Johnson and Rotor syndrome. In Dubin-Johnson syndrome, it is due to mutation in MRP2, multi-drug resistant protein 2, also known as multi-anion specific organic anion, multispecific organic anion transporter, also known as multispecific organic anion transporter, MRP2, multi-drug resistant protein 2, also known as ABCC2, ABCC2, ATP binding cassette transporter C2. There is mutation in this protein which is important for excretion of bilirubin, It is important for secretion of bilirubin, active secretion of bilirubin by the bile canaliculi. And it is important in the rate limiting step in the bilirubin metabolism. So bilirubin excretion does not occur, conjugated bilirubin excretion does not occur. So that's why there is increase in the direct bilirubin in the Dubin-Johnson syndrome. Another feature is there is black liver because of accumulation of epinephrine metabolite, that is metanephrine. Epinephrine metabolite accumulates, that causes the black colored jaundice or black liver jaundice, also known as. So there is defective excretion of conjugated bilirubin in the Dubin-Johnson syndrome. Remember, in Dubin-Johnson syndrome, there is direct hyperbilirubinemia. In the Rotor syndrome, there is direct hyperbilirubinemia. There is increase in the direct bilirubin. This is due to mutation in organic anion transporter 1B1 and 1B3. Organic anion transporter 1B1 and 1B3. ये किस चीज के लिए लग रहा था हमको? एक्टिव सिक्रेशन ऑफ बिलिरुबिन इनटू बाइल कैनालिकुलाई. This is required for reuptake of conjugated bilirubin by the hepatocyte. What is function of this? Reuptake of conjugated bilirubin by hepatocytes. And if this is defective, it causes Rotor syndrome. So that causes increase in the direct bilirubin level. So direct bilirubin level increases in Dubin-Johnson and Rotor, DR, Dubin-Johnson and Rotor syndrome. While in unconjugated bilirubin or unconjugated or indirect bilirubin level increases in Crigler-Najjar. There are two types, type 1, type 2 and Gilbert disease. So Crigler-Najjar type 1, it is due to complete deficiency of UDP glucuronil transferase, which is required for the conjugation of bilirubin, So deficiency, severe or complete deficiency of UDP glucuronil transferase causes the Crigler-Najjar type 1, and partial deficiency means less than 10% activity of UDP glucuronil transferase retained in this type 2 disease. So it is less severe. In this, the bilirubin can go about 20 milligram per deciliter, 20-25 milligram per deciliter in type 1. So this is less severe. Bilirubin level go up to 20, not beyond that. In the type 2 Crigler-Najjar syndrome, there is increase in the indirect bilirubin or unconjugated bilirubin. While in the Gilbert disease, there is defective uptake of bilirubin and 10 to 33% activity of UDP glucuronil transferase is retained. It is autosomal dominant and defect in uptake of bilirubin. Bilirubin can go up to 4 milligram per deciliter in the Gilbert syndrome. So remember this. पहले तो ये चीजें याद रखो. Indirect hyperbilirubinemia or increase in the unconjugated bilirubin that occurs in the Crigler-Najjar syndrome type 1, type 2 and Gilbert's disease. And increase in the direct bilirubin, it occurs in the Dubin-Johnson syndrome and Rotor syndrome. ये पहले याद रखो, ये याद रह गया. इसके बाद में इनके पॉइंट याद रखो. MRP2 mutation is there in Dubin-Johnson syndrome. Also there is black liver. And in Rotor syndrome, there is organic anion transporter 1B1 and 1P3 defect. This is required for reuptake of conjugated bilirubin by the hepatocytes. Then indirect bilirubin level increases in Crigler-Najjar type 1 and type 2 and Gilbert's disease. There is defect in the conjugation. Conjugation is required for conversion of unconjugated, toxic unconjugated bilirubin into the water soluble conjugated bilirubin. So these are the different types of hyperbilirubinemia. Okay. Now the coming to the lipoproteins. So this is again important topic, lipoproteins and disorders. Lipoproteins and disorders. This is important topic. Now see, lipoprotein, lipid plus proteins, lipoproteins. So there is problem of carrying the lipids. because they are insoluble in water, and aqueous phase they are insoluble. So the problem of transport of lipid, it is overcome by combining the lipid with the protein. So that's why it is known as lipoproteins. Now what are the points to remember from this lipoprotein? So chylomicron, VLDL, IDL, LDL and HDL, these are the lipoproteins. Now remember the protein content, you will automatically remember the lipid content of these lipoproteins. So lipid protein, they are composed of lipid protein, and what is important role? Carrying the TG. ये किस चीज के लिए बनाए गए हैं? टू ट्रांसपोर्ट द लिपिड. सो दे विल कैरी द टीजी, दे विल कैरी द कोलेस्ट्रॉल. तो ये जो दो है काइलोमाइक्रॉन और वीएलडीएल, दे विल कैरी द टीजी, एंड आईडीएल, एलडीएल, एचडीएल, दे विल कैरी द कोलेस्ट्रॉल. ये टीजी कैरी करेंगे, ये कोलेस्ट्रॉल कैरी करेंगे. ठीक है. नाउ सी, प्रोटीन कंटेंट इन काइलोमाइक्रॉन इज 1%. In VLDL it is 7 to 10%. Then in IDL it is 11%. In LDL it is 21%, and HDL it is 30 to 60%. It is 30 to 60%. Now the lipid content, it is 99% lipid in the chylomicron, the 90 to 93% in the VLDL, 89% in the IDL, 79% in LDL, and 40 to 70% in HDL. The principal lipid in chylomicron is TG, VLDL is TG, IDL, LDL and HDL it is cholesterol. It is cholesterol. Okay. Now apoprotein. Apoprotein means protein part. Lipoprotein के दो पार्ट है, एक लिपिड एक प्रोटीन. तो लिपिड या तो टीजी रहेगा, या तो कोलेस्ट्रॉल रहेगा, या तो फॉस्फोलिपिड रहेगा. और प्रोटीन, जो प्रोटीन पार्ट है उसको बोलते हैं अपोप्रोटीन. जो प्रोटीन पार्ट है उसको बोलते हैं अपोप्रोटीन. इंटीग्रल अपोप्रोटीन भी रहेंगे, पेरिफेरल अपोप्रोटीन भी रहेंगे. तो अपोप्रोटीन, द मेजर अपोप्रोटीन इन काइलोमाइक्रॉन इज B48. B48, here it is B100, VLDL, IDL, LDL, ये एक ही साइकिल में बनते हैं, VLDL, IDL एंड LDL. तो B100 इनका मेजर लाइपोप्रोटीन है. ठीक है. ये 100% बैड है, मतलब रिमेंबर न्यूमोनिक के लिए ये 100% बैड है, इसलिए इसके साथ कोई और अपोप्रोटीन नहीं है. 100% बैड है. द अपो B100 एंड अपो B48, these are the example of RNA editing. Examples of RNA editing. This is produced by the intestine. This is produced by the liver. B100 it is produced by the liver. This is produced by the intestine. B48, only 48% is synthesized because of premature truncation of protein synthesis, because of incorporation of uracil instead of cytosine. Cytosine is converted into uracil. So UAA. So UAA is the stop codon. Because of insertion of stop codon, premature truncation of protein synthesis occurs, and only 48% is produced in the intestine. So this is example of RNA editing. This is example of RNA editing. So remember, so 48, B100, B100, B100 and ApoA1. So these are the major apoproteins in the HDL. So chylomicron is important for carrying the dietary triacyl glycerol, जो हम खाते हैं, exogenous triacyl glycerol. VLDL, it is important for carrying the endogenous TG, which is the produce in the liver. Liver में जो TG बन रहा है उनको carry करेगा. LDL, this is intermediate in between VLDL and LDL synthesis, also known as remnant VLDL. LDL is important for carrying the cholesterol from liver to the peripheral tissues, while HDL, it is important from carrying the cholesterol from peripheral tissue to the liver. So it is important in the reverse transport of cholesterol. So also known as good cholesterol. Also known as good cholesterol. These are the major apoproteins. This is B40. B48 it is present in the chylomicron. B100 it is present in VLDL, IDL, LDL. Apo C1, C2, C3. These are the apoproteins. Apo C1, C2, C3. Now remember AC23. AC23. Apo A2. Apo A2 and C3. C3 inhibit lipoprotein lipase. AC23 inhibit lipoprotein lipase, means Apo A2 and C3 inhibit lipoprotein lipase. C3 and Apo A2 inhibit lipoprotein lipase. Apo A1 activates LCAT. Where is A1? A1 activates LCAT. A1 activates LCAT, lecithin cholesterol acyl transferase, and it is important in the esterification of cholesterol. So nascent discoidal HDL becomes spherical HDL in with this LCAT, lecithin cholesterol acyl transferase. So remember these points here. C2 activates the lipoprotein lipase. C2 activates lipoprotein lipase. Now the hyperlipoproteinemia. This is a trending topic now. Hyperlipoproteinemia. अगर सारे के सारे याद नहीं रहते तो भी टाइप 1 और टाइप 2 ये दो याद रखो. टाइप 1 और टाइप 2 ये दो याद रखो. दिस इज फ्रेडरिक्सन क्लासिफिकेशन ऑफ hyperlipoproteinemia. Okay. Whenever there is increase in the cholesterol, it causes tendon xanthoma. It involves the tendons. And tendon xanthoma is there, lesion is there on the tendon. So it occurs in type 2A, hypercholesterolemia. It is familial hypercholesterolemia, type 2A. Whenever there is increase in the triglyceride level, it causes the eruptive xanthomas. The papular lesions around in the inner canthus of the eye, like that. The eruptive xanthomas, it occurs when there is increase in the TG, and triglyceride level increases in the type 1, type 4 and type 5. Type 1, type 4, type 5. 1, 4 and 5. There is increase in the TG, it causes eruptive xanthoma. Also it causes pancreatitis. Because of increased TG level, it causes pancreatitis. These persons, when TG increases, they are prone for the pancreatitis, while they are prone for the coronary artery diseases because of increase in the cholesterol level. Okay. And whenever there is increase in the chylomicron, as it occurs in the type 1 disorder, so it gives milky plasma. The plasma looks like milk. It is milky plasma appearance, or opalescent plasma is there when chylomicron levels are raised. Okay. So remember these three are important for the diagnosis. मैंने क्या बोला था, ये सारे के सारे याद नहीं रहते तो मत रखो, पहला और दूसरा याद रखो. First, the familial chylomicronemia. There is increase in the chylomicron. और chylomicron क्या कैरी करता है, कौन सा लिपिड कैरी करता है, एक्सोजिनस ट्राइएसाइल ग्लिसरॉल. तो इसमें chylomicron भी बड़ा रहेगा और TG भी बड़ा रहेगा. सी, chylomicron भी बड़ा है, TG भी बड़ा है. Okay, it is because of lipoprotein lipase deficiency or ApoC2 defect. Because ApoC2 is required for activation of lipoprotein lipase. So lipoprotein lipase deficiency or ApoC2 defect. So there is eruptive xanthomas and they are prone for the pancreatitis because increase in the triglyceride level. Okay, ये याद रखो एक, और ये दूसरा familial hypercholesterolemia type 2A. It is because of LDL receptor defect or ApoB100. Defect in the ApoB100. There is increase in the LDL level and there is increase in the cholesterol level that causes tendon xanthomas, and they are prone for atherosclerosis and coronary artery diseases. Type 3 also known as, type 2B is the familial combined dyslipidemia. Type 3 is familial dys-beta lipoproteinemia. Type 4 is familial hypertriglyceridemia, and type 5 is also familial hypertriglyceridemia. So in 4 and 5, there is increase in the TG level, there is increase in the VLDL level, and they are prone for the eruptive xanthomas. Remember these points in the type 4. It is associated with glucose intolerance, hyperinsulinemia, and it is associated with coronary artery diseases, alcoholism, obesity, and diabetes mellitus. Coronary artery diseases, alcoholism, obesity, and diabetes mellitus. Type 4. Hypertriglyceridemia. Okay. Remember type 1, there is increase in the TG, they are prone for pancreatitis. Type 2A, there is increase in the cholesterol, they are prone for coronary artery diseases, atherosclerosis. So remember type 1 and type 2. This is due to lipoprotein lipase deficiency, which is frequently asked question. Opalescent plasma, milky plasma is there. Okay. In the familial chylomicronemia. While in the familial hypercholesterolemia, there is increased LDL, there is increase in the cholesterol level, there is tendon xanthomas, and statins. We will give the statin to reduce the cholesterol level. We'll give the statins. And hypolipoproteinemia. In hypolipoproteinemia, what is important? Important. There is mutation or defect in the transporter, ABC transporter protein, that is ABCA1, which is important for transfer of cholesterol from cells to HDL, from cells to HDL, transfer of cholesterol from cells to HDL, and it is important in the changing the cholesterol from the nascent discoidal to the spherical HDL. So it is important in the HDL cycle. It is important in the reverse transport of cholesterol. Tangios disease due to mutation in ABCA1. ABCA1. There is orange colored tonsil in the Tangios disease. This is hypolipoproteinemia. Hypolipoproteinemia. There is low level of HDL and ApoA1. Enlarged yellow-orange tonsil. Yellow-orange tonsils. Hepatosplenomegaly and peripheral neuropathy is there. Fisheye disease. There is partial deficiency of 𝐿-CAT, that is lecithin cholesterol acyl transferase, and Norom's disease, there is complete deficiency of the lecithin cholesterol acyl transferase. See this image, orange colored tonsil. This is the feature of Tangiers disease, hypolipoproteinemia. Hypolipoproteinemia. There is defect in the HDL because of mutation in ABCA1, because this ATP binding cassette transporter protein is required for transport of cholesterol from the cells to the HDL, and then 𝐿-CAT will causes the esterification of this cholesterol and converts cholesterol into cholesterol ester. As it becomes cholesterol ester, it is a lipid and it will move to the interior of HDL core, and now the HDL becomes spherical. So this is orange colored tonsil. A patient presented with reduced level of high density lipoprotein and ABCA1. On examination, tonsil appeared as shown in the image. What is diagnosis? It is a Tangiers disease. It is a Tangiers disease. Now, this is a frequently asked or repeatedly asked question in any entrance examination. NEET PG examination, INICET, also FMG. The tissue paper appearance or wrinkled paper appearance of the cell. The Gaucher's cell, bone marrow appearance, typical tissue paper or wrinkled paper appearance because of accumulation of glucocerebrosides, in the Gaucher's disease. This is a frequently asked question, and this is a must read topic, that is lipid storage disorder, lysosomal storage disorders. Gaucher's disease, Niemann-Pick disease, then Tay-Sachs, Sandoff's disease. These are very, very important for the entrance examination. Principally, the most important one is the Gaucher's disease. Now see, we'll see. A patient presented with refractory anemia. Refractory anemia means not responding to the treatment. A histological picture is shown with the cells in the bone marrow. This is a picture. It is known as crumpled tissue paper appearance or wrinkled paper appearance. Which of the following enzyme is deficient? Here, there is accumulation of glucocerebrosides. So the enzyme defect is glucocerebrosidase. This enzyme is defective in the Gaucher's disease. This is Gaucher's disease. So if it affects the liver, spleen and bone marrow, as bone marrow is affected, there is pancytopenia, means anemia is there, leukopenia is there, neutropenia is there, thrombocytopenia is there. Because of thrombocytopenia, because of decrease in the platelet count, there is bruising disorders, means the bleeding occurs, thrombocytopenia. And also there is the bone deformity, the long bone, the femur particularly, that is known as Erlenmeyer flask deformity. जो end रहते bone के वो ऐसे flask जैसे हो जाते, that is known as Erlenmeyer flask deformity. एक्सरे में दिखता है ये फीचर. और microscopically there is tissue paper, wrinkled tissue paper appearance because of the intracytoplasmic inclusion bodies, the Gaucher's cell, because of Gaucher's cell, because of defect in the glucocerebrosidase enzyme, which is important for the degradation of glucocerebrosides. So glucocerebrosides, they are by the glucocerebrosidase, they are converted into ceramide plus glucose. So because of degradation, there is block in the degradation, there is accumulation of glucocerebrosides. A child presented with difficulty in vision. On examination, cherry red spot on the macula, and there was no organomegaly. Remember this point, no organomegaly in the lysosomal storage disorder. This might be a Tay-Sachs disease. This might be a Tay-Sachs disease, that is GM2 gangliosidosis. Identify the disease. Okay. So in Gaucher's disease, there is no cherry red spot. There is no cherry red spot in three disorder, KGF, Krabbe's, Gaucher and Fabry's disease. There is no cherry red spot. No cherry red spot on macula. This is because of accumulation of lipid in surrounding area around the macula and skipping the macula. So macula will appear red. So cherry red spot in the retina. This is a feature of lysosomal storage disorder, except KGF, Krabbe's disease, Gaucher's disease and Fabry's disease. Now remove this. Gaucher's disease, it is removed. Then Hunter disease. See, this is mucopolysaccharidosis, Hunter disease. There is no corneal clouding. But retinal involvement is there, but there is no cherry red spot in the Hunter's disease also, mucopolysaccharidosis. Now left, Tay-Sachs disease and Niemann-Pick disease. Niemann-Pick disease, it is due to sphingomyelinase defect, and there is hepatosplenomegaly and there is cherry red spot on the macula. Tay-Sachs disease, there is cherry red spot on the macula. This is the GM2 gangliosidosis. There is cherry red spot on the macula, but there is no organ involvement. There is no organ involvement in the Tay-Sachs disease. The Sandoff disease, which is due to defect in the hexosaminidase A and B. In Sandoff disease, there is hepatosplenomegaly along with this feature. Sandoff's disease. Okay, but not in the Tay-Sachs disease. Now see again this. Following is the bone marrow biopsy picture from a child with hepatosplenomegaly and pancytopenia. The characteristic cell seen in the biopsy is a diagnostic finding of which of the following disease. So this is a Gaucher's disease. This is a Gaucher's disease. Now see, this is Erlenmeyer flask deformity in the X-ray. Erlenmeyer flask deformity in the X-ray. Now see, this is Erlenmeyer flask in the X-ray. So this is a feature of Gaucher's disease. Now this is cherry red spot on the macula. It is not seen. Remember, not seen in KGF, Krabbe's disease, Gaucher's disease and Fabry's disease. It is not seen. The following fundoscopy depict a characteristic finding. The finding is present in all of the following disease except, so it is not present in KGF, Krabbe's, Gaucher and the Fabry's disease. So it is present in Niemann-Pick, Tay-Sachs, Sandoff disease, but not in the Gaucher's disease. So these are the disorders, lysosomal storage disorders: Gaucher's, Niemann-Pick, Krabbe's, Fabry's, Tay-Sachs, Sandoff, metachromatic leukodystrophy and Fowler's disease. Remember, of this, there is no cherry red spot on the Gaucher's, in the Gaucher's disease, Krabbe's disease, Fabry's disease. Fabry's disease is X-linked. This one is the X-linked Fabry's disease, and it is associated with angiokeratomas. It is associated with angiokeratomas. Tay-Sachs disease, there is no organomegaly. Sandoff disease, along with the features of Tay-Sachs disease, in Sandoff disease there is organomegaly, means hepatosplenomegaly. In Niemann-Pick disease, there is cherry red spot on the macula, there is mental retardation, and there is this is due to defect in the sphingomyelinase, and in Niemann-Pick disease there is hepatosplenomegaly. So Gaucher's disease, it is beta glucosidase or glucocerebrosidase defect, and there is accumulation of glucocerebrosides. There is accumulation of glucocerebroside. See, ceramide. Ceramide मतलब क्या होता है? Ceramide means fatty acid plus sphingosine. Sphingosine is the 18 carbon amino alcohol. Sphingosine is the 18 carbon amino alcohol. So इसको बोलते हैं ceramide. When glucose is added to ceramide, it is glucocerebroside. Glucosyl ceramide or glucocerebroside. It is known as glucocerebroside. अगर गैलेक्टोज ऐड किया तो गैलेक्टोसेरेब्रोसाइड. ठीक है, अगर गैलेक्टोज ऐड किया तो गैलेक्टोसेरेब्रोसाइड, ग्लूकोज ऐड किया तो ग्लूकोसेरेब्रोसाइड. इतना समझ में आया? Means fatty acid plus sphingosine plus glucose is the glucocerebroside, means fatty acid plus sphingosine plus galactose is the galactocerebroside. When fatty acid means ceramide plus oligosaccharide is there, it is known as globoside. And when ceramide plus oligosaccharide containing NANA, N-acetyl nuraminic acid, it is known as ganglioside. It is known as ganglioside. So glucocerebroside, the degradation glucocerebrosidase, it will cleave this glucocerebroside into glucose plus ceramide. When there is defect in this, it causes Gaucher's disease. There is accumulation of glucocerebrosides in the various tissues, specifically liver, spleen and bone marrow. लिवर, स्प्लीन एंड बोन मैरो. तो इसमें से क्या याद रखना है कि केजीएफ में चेरी रेड स्पॉट नहीं रहता. Niemann-Pick disease is due to sphingomyelinase defect. Gaucher's disease is due to beta glucosidase defect or glucocerebrosidase defect. What is accumulated in Gaucher's disease? Cerebroside. And what is accumulated in Niemann-Pick disease? That is sphingomyelin. Because this is defect in the sphingomyelinase. Okay. Now, in Fabry's disease, there is telangiectatic skin lesion. They are known as angiokeratomas, and it is a X-linked disorder. Tay-Sachs disease, there is progressive neurological involvement and there is no organomegaly. Sandoff disease, there is organomegaly along with the intellectual disability. So these are the points to remember. So these are the important lysosomal storage disorders. Okay. Now from the nutrition topic, see the SDA, caloric value and the respiratory quotient. This point is important, particularly this point is important, SDA. It is also known as thermic action of the food. Thermogenic action or thermic action of the food. Above the BMR, extra amount of energy is required for the processing of the food. For processing of the food, this amount of energy is required for their metabolism, their transport and storage. So 5 to 10% is required for the carbohydrate, lipid it is 0 to 5% and protein 30% is required. That's why it is a good food for weight loss. It is good food. It is a food for maintaining the diet, protein. 30% extra amount of energy is required for processing the food. That is known as SDA value or thermic action of food or calorigenic action of the food. So this is important MCQ, protein. 30% extra. So this should be kept in the mind while calculating the energy requirement of an individual. 3 point हम याद रखते. पहला is the BMR, basal metabolic rate. दूसरा is the SDA, that is specific dynamic action of the food or thermic action of the food. And तीसरा physical activity, whether it is light, moderate or heavy exercise. Or work, light work, moderate work or heavy work. Depending on that, energy requirement is calculated. So thermic action or SDA of the food, that is specific dynamic action of the food. It is more in case of the protein. In case of the mixed diet, it is 10%. So remember, it is 30% for the protein. It is required for the required for the transamination reaction. It is required for the urea synthesis. It is required for the protein biosynthesis. It is required for the absorption, transport and storage of the food. So over and above the BMR, the extra amount of energy is required for processing the food. That is known as thermic action, SDA of the food. So it is maximum in case of the protein. Now caloric value means this amount of energy is provided by this foodstuff. Carbohydrate will give 4 calorie per gram, lipid will give 9 calorie per gram and protein will give the 4 calorie per gram. While respiratory quotient, it is the amount of CO2 produced to the O2 utilized. So it is 1 in case of the carbohydrate, while 0.7 in case of lipid, and protein it is 0.8. Protein it is 0.8 and for the mixed diet it is 0.85. So this chart is important, SDA, caloric value and the respiratory quotient. Hemoglobin saturation curve is important and negative effectors which shift the oxygen dissociation curve, to the right. It is important. So it is shift to the right in presence of negative effector. It is a partial pressure of O2 and hemoglobin percent saturation. So it is negative effectors. Increase in the H ion concentration, then CO2 level, 2,3 BPG bisphosphoglycerate, and the temperature. These are the negative effectors that shift the oxygen dissociation curve to the right. It is a sigmoidal shaped dissociation curve. In case of myoglobin, see, in case of myoglobin, is curve is like this. This is a curve of myoglobin. While it is sigmoidal in shape in case of the hemoglobin, because of cooperative binding, because of cooperative binding of oxygen to the hemoglobin. What is meaning of cooperative binding? When one molecule of oxygen attached to the hemoglobin, the subsequent O2 attaches to the hemoglobin with more affinity than the previous one. That is known as cooperative binding. And the curve in this is the sigmoidal in shape. So these are the negative effector. This will shift, increase in the H ion concentration, CO2, partial pressure of CO2, 2,3-bisphosphoglycerate, which is generated in Rapoport-Lubering cycle, and temperature, increase in the temperature will shift the curve to the right. Carbon monoxide, fetal hemoglobin will shift the curve to the left. These are the negative effectors. This is myoglobin curve. So oxygen dissociation curve, cooperative binding, and negative effectors that will shift the curve to the right, and that causes unloading of oxygen to the tissues. This is very, very important. For example, 2,3-BPG, it is important in the high altitude hypoxia anemia. It is important, 2,3-bisphosphoglycerate. So this is oxygen dissociation curve. Now coming to the amino acid metabolism, there are various inborn errors in the amino acid metabolism. Phenylketonuria, alkaptonuria, maple syrup urine disease, homocystinuria. These are the different disorders in the protein metabolism. Now see, the mousy odor or musty odor, this is important. It is seen in phenylketonuria because of excretion of phenyl acetate in the urine. This is because of deficiency of phenylalanine hydroxylase. So phenylalanine is diverted for the production of various products: phenyl pyruvate, phenyl lactate, phenyl acetate, phenyl acetylglutamine. So that will give the odor, mousy odor to the urine in the phenylketonuria. Now sweety feet odor, it is in the isovaleric acidemia, acidemia. The burnt sugar, it is very, very important and frequently asked question. It is in the maple syrup urine disease. So there is intellectual disability, the floppy infant, intellectual disability, and smell of burnt sugar because of increased excretion of alpha keto acids and their respective amino acid, valine, isoleucine, leucine in the urine, maple syrup urine disease. The boiled cabbage odor in the tyrosinemia, that is type 1 tyrosinemia. The rotten fish odor in trimethyl aminuria, swimming pool odor in Hawkins-urea, and tomcat urine odor in multiple carboxylase deficiency. These four are very, very important to remember. Okay. Now coming to the DNA repair mechanism. This is important chart, repair mechanism. DNA repair mechanism. So these are the DNA damaging agent. DNA can be damaged by the physical agent. They can be damaged by the chemicals. They can be damaged by the reactive oxygen species or free radicals which are generated in our body via the various metabolic reactions. So these are the DNA damaging agents. These are the DNA lesions, means double strand break, single strand break, thymidine dimer formation, pyrimidine dimer formation. Then base substitution, single base alteration, two base alteration. These are the lesions. See, double strand break, single strand break, intrastrand crosslinks or interstrand links, interstrand crosslinks, pyrimidine dimer formation. This is UV light induced thymine dimer formation. Then creation of a basic site or single strand break or mismatch. These are the various DNA lesions caused by these DNA damaging agents. Now these are the repair mechanism, important repair mechanism that includes non-homologous end joining, which is a common mechanism in case of double strand break repair in the mammals. Non-homologous end join is homologous recombination. Then nucleotide excision repair, base excision repair, and mismatch repair. These are the different repair mechanism. This is the most common mechanism in the mammal, non-homologous end joining. मतलब जैसे दो स्टैंड अगर कटे हुए हैं तो उसको वैसे के वैसे ज्वाइन कर दो with the help of Ku protein which has helicase activity, which recruits the DNA dependent protein kinases. DNA dependent kinases, they will causes the approximation of strand and ligation of strand will occur. So Ku protein and DNA dependent protein kinase dependent repair is there, non-homologous hand joining that can cause mutation because, but it is better than loss of chromosome. So non-homologous end joining. So double strand break repair, the most common is the non-homologous end joining. This is the repair mechanism. And the disease which is related with non-homologous end joining is severe combined immunodeficiency. Severe combined immunodeficiency. This is severe. Remember this severe combined immunodeficiency. This was the first disease for which then gene therapy was tried. Okay. Then the second is the homologous recombination. This is from the sister chromatid, the similar part of the DNA, the similar DNA from the sister chromatid. It is used for the synthesis of the new strand, and it is known as homologous recombination. The defect in homologous recombination can cause ataxia, telangiectasia like disorder, Bloom syndrome, pressure susceptibility, that is BRCA1 and BRCA2. So these are the important diseases to remember. Repair related with double strand break repair, that is homologous recombination. Ataxia, telangiectasia like disorder, Bloom syndrome, breast cancer susceptibility. Then thymine, UV light induced thymine dimer formation. This type of bulky lesion, it is repaired by the nucleotide excision repair. And the defect in nucleotide excision repair can cause xeroderma pigmentosum, that is characterized by multiple freckles on sun exposed part of the body. Multiple freckles, it is a precancerous condition characterized by multiple freckles. ऐसे बहुत सारे तिल आ जाते हैं, तो multiple freckles on sun exposed part of the body, xeroderma pigmentosum or Coca-Cola syndrome. Okay, so this is very important to remember. This will repair the thymine crosslinks, crosslinks in the DNA because of UV light induced. Then abasic sites, when there is damage base, when only base is damaged, nitrogen base is damaged, and if there is creation of abasic site, it is repaired by the base excision repair. And when there is mismatch, means incorrect base is added, according to the Watson and Crick base pairing, against the adenine there is thymine, and against the guanine there is cytosine. If incorrect base is added, it is repaired by the mismatch repair. So this is again important. So hereditary non-polyposis colorectal cancer is important disease which is related with the mismatch repair, also known as Lynch syndrome or hereditary non-polyposis colon cancer. यहाँ पे 3 या 4 diseases important है. Hereditary non-polyposis colon cancer, it is due to defect in mismatch repair. Xeroderma pigmentosum, it is due to defect in nucleotide excision repair. Then these ataxia, telangiectasia, Bloom syndrome, breast cancer susceptibility, Werner syndrome. These are due to the double strand break repair, defect in double strand break repair, that is homologous recombination. And SCID, severe combined immunodeficiency, it is due to the non-homologous end joining defect due to repair due to defect in the double strand break repair. So this chart is very, very important for your INICET exam. So prepare this chart. Okay. Now this is related with copper 2 disorder, that is Wilson's disease and Menkes disease. It is important. Wilson's disease, Menkes disease. There is in Menkes disease there is deficiency of copper. In Wilson's disease there is copper excess and golden brown color ring around the cornea in the descendant membrane of the cornea, that is known as KF ring, Kaiser-Fleischer ring. That is known as Kaiser-Fleischer ring, golden brown ring around the cornea. There is excess of copper and it deposited in the various tissue, that is known as hepatolenticular degeneration. Hepatolenticular मतलब liver में और lenticular nucleus of brain, hepatolenticular degeneration. Wilson's disease is also known as hepatolenticular degeneration. There is excess of copper. So incorporation of copper into ceruloplasmin is defective and excretion of copper into bile is defective because it is due to mutation in the 7B. Remember, M comes first, so it is A, and W comes after the M, so it is B. ATP 7A, 7B. So Menkes disease, there is mutation in ATP7A which is required for absorption of copper from the intestine, while Wilson's disease, it is due to defect in ATP7B. It is required for excretion of copper and incorporation of copper into the ceruloplasmin. So Wilson's disease is hepatolenticular degeneration. There is involvement of brain and the liver. There is involvement of the lens. There is sunflower cataract in the lens and the KF ring in the cornea. Golden brown color or green colored ring around the cornea, that is known as KF ring. In Menkes disease, there is brittle hair, easily pluckable hair. The mental retardation is there. Hypopigmented patches is there because there is defect in the copper, decrease in the copper level. Menkes disease. Okay. Now, what is telomere? What is telomere? It is a TTAGGG6 nucleotide repeat. TTAGGG6 nucleotide repeat at the end of the chromosome. It prevents the loss of chromosome and it prevents the end replication error. So it is a 6 nucleotide repeat. Near about 15,000 base pairs are there, and it is maintained by the telomerase enzyme. Telomerase enzyme is telomere terminal transferase. It is having the reverse transcriptase activity. It is having this is telomere terminal transferase. It is complementary to the telomere repeat with reverse transcriptase activity. It is absent in the somatic cell. It is present in the germ cell and stem cell. It is absent in the somatic cell. Somatic cell में absent रहेगा और germ cell और stem cell में present रहेगा. Increase activity in the cancer and decrease activity with aging. With repeated cell division, so some shortening of the chromosome occurs. So decrease with the aging. Telomere length decrease with the aging, and corrects the end replication error. So TTAGGG6 nucleotide repeat at the end of the chromosome that prevents the fusion of the chromosome, that prevents the loss of information from the DNA molecule. So after the repeated replication, there is some shortening of the DNA occurs. That is known as end replication problem, and this because of telomere, it corrects the end replication error. So it maintains the length of the DNA. There is 6 nucleotide repeat, that is known as telomere. It is maintained by the telomerase enzyme. There is increased telomerase activity in the cancer and decrease with the aging. It is present in the germ cell and stem cell but absent in the somatic cell. So these are the important points related with telomere and telomerase. In the acid-base balance, how to diagnose the acid-base balance? See, 7.35 to 7.445 is the normal range. If it is below 7.35 means it is acidosis. If it is above 7.45 means it is alkalosis. If below 7.35 it is acidosis. If above 7.45 it is alkalosis. Above 7.45 it is alkalosis. So this is primary defect. जो pH के साथ जाएगा वो प्राइमरी डिफेक्ट. रिमेंबर, इसको देख के आपको एसिडोसिस अल्कोलोसिस पहले डिसाइड करना है. ये आपका एक बार डिसाइड हो गया pH के भरोसे पे, देन विल सी द मेटाबॉलिक और रेस्पिरेटरी कंपोनेंट. ओके, सो ये अगर ये बोल रहा है एसिडोसिस तो प्राइमरी डिफेक्ट उसका एसिडोसिस ही रहेगा. ठीक है. Now see the bicarbonate level. Bicarbonate is the base. If base decreases, it is acidosis. If base increases, it is alkalosis. And this is metabolic component. Bicarbonate is the metabolic component. If bicarbonate level decreases, it indicates the metabolic acidosis. And if bicarbonate level increases, normal level is to 22 to 28. If bicarbonate levels are increases, means alkali reserve. If increases, it is alkalosis. So metabolic. Bicarbonate is the metabolic component. And partial pressure of CO2 is 35 to 45 mmHg. If it is increases, carbonic acid, CO2 means dissolved carbonic acid. So carbonic acid अगर बढ़ गया तो acidosis. So carbonic acid is the respiratory component. CO2 is the respiratory component. So if it increases, it indicates the respiratory acidosis. If it decreases, it indicates the respiratory alkalosis. बाइकार्बोनेट क्या है? बेस. बेस अगर डिक्रीज हो गया, अल्कली अगर डिक्रीज हो गया तो एसिडोसिस, अल्कली बढ़ गया तो अल्कलोसिस. ये क्या है? एसिड, कार्बोनिक एसिड. कार्बोनिक एसिड बढ़ गया तो एसिडोसिस, कार्बोनिक एसिड कम हो गया तो अल्कलोसिस. सेम, दिस इज द प्राइमरी डिफेक्ट. जो पीएच के साथ जाएगा दैट इज प्राइमरी डिफेक्ट. जो पीएच के साथ जाएगा वो प्राइमरी डिफेक्ट. ओके. So there are various causes of metabolic acidosis, alkalosis, respiratory acidosis, alkalosis. So prepare that causes. Okay. Also the high anion gap metabolic acidosis, normal anion gap metabolic acidosis. Remember diarrhea, renal tubular acidosis 1, 2 ka 4, 1, 2 and 4. Renal tubular acidosis 1, 2, 4. These are the causes of normal anion gap metabolic acidosis. And the diabetic ketoacidosis, diabetic ketoacidosis, lactic acidosis, organic acidurias, renal failure. These are the causes of high anion gap metabolic acidosis. Now see, these are the blotting techniques: southern blotting, northern blotting, and western blotting. Southern blotting, northern blotting, and western blotting. Southern blotting is a technique for the DNA. It is southern. It is given by the Edward Southern. That's why the name. It is the blotting technique for the DNA. Northern blotting is for the RNA, and the western blotting it is for the protein. Western blotting it is for the protein. For DNA protein interaction, it is DNA footprinting. For the DNA and protein interaction, it is DNA footprinting. Okay. Southern, northern, and western: DNA, RNA, and protein. Okay. So this is all about the previous year topics. So you can see the PDF and you can watch the PDF. There are number of MCQs from different INICET examination. So we can cover that. By just reading, you can answer these questions, different questions from the different INICET examination. So this is all for today. We'll take some images. Just wait. See, this is black pigmentation. See, black deposits in the urea, where urine turns dark on standing, urea, because of defect in homogentisate oxidase, and homogentisate is converted into alkaptone, the black color pigment, which causes deposition in the various tissues. So this is urea. Also causes the chronic arthritis. This is the albinism, generalized hypopigmentation, because of defect in the tyrosinase enzyme. Because of defect in the tyrosinase enzyme. Then this is niacin deficiency, Castle's necklace. Niacin deficiency, Castle's necklace in the appearance, Castle's necklace dermatitis, diarrhea, dementia, dermatitis, pellagra. So this is the Castle's necklace due to deficiency of niacin, causes the pellagra. Okay, this is homocystinuria, where inferomedial subluxation of the lens occur. Inferomedial subluxation of lens occur. Homocysteine. There is increased homocysteine level. It reacts with the collagen crosslinks, and there is inferomedial subluxation of lens, ectopia lentis. Homocystinuria, it is due to the defect in the cystathionin beta synthase. Cystathionin beta synthase, and in homocystinuria, there is elevated levels of homocysteine, also elevated level of methionine is there, and cysteine levels are decreased, so cysteine has to be supplemented in the diet. So this is all about the important topics related with INICET. So thank you.